In 1992, Congress struck a deal with pharmaceutical manufacturers to expand access to care and medication for more patients. If pharmaceutical manufacturers wanted to be included in Medicaid's coverage, they'd have to offer their products to outpatient entities, serving low-income patients at a discount. The idea was brilliantly simple. Drug manufacturers could have a guaranteed income from participation in the Medicaid program, and covered entities could have guaranteed access to discounted medications. Congress set up a payment system by way of rebates and discounts, affording certain healthcare providers a way to fund much-needed care to patients who could not otherwise afford it. This payment program is little known, but is now significantly large. It is the 340B drug pricing program. For nearly 3 decades, the 340B program has greatly expanded access to care and medication for underserved communities. But many public health advocates are asking how the program can be improved to serve even more patients. All public-private partnerships require transparency to instill confidence in the program. It brings us more accountability and more effective programs. Transparency helps to identify areas of improvement in operations or enforcement, as well as limiting waste, fraud, and abuse. Transparency in the 340B program ensures investments into patient access to care and medications for critically vulnerable populations and reaching patients. Accountability is often broadly discussed on a variety of levels about governmental and social issues, and the 340B drug pricing program is certainly no exception. The 340B program exists to address the healthcare needs of a segment of society, social needs. As such, program accountability is of paramount importance since patient health depends on it. These needs are often met through charity care. A cornerstone argument in favor of the 340B program centers on so-called charity care rates of participating disproportionate share hospitals, DSH. Those covered entities, specifically DSHs, should be able to leverage their 340B dollars to extend care and outpatient medications to offset losses from uncompensated care. In the ideal, offsetting the costs associated with charity care to provide more care to low-income patients is noble and moral and just, and an ideal society should support. The problem occurs when charity care doesn't match the needs of the community. The 340B program has witnessed explosive growth over the last decade, but unfortunately it hasn't always translated into greater access to care and medication. Contract pharmacies represent one of the largest areas of growth in the program, operating as middlemen, with their hands in the proverbial cookie jar. Since not all contract pharmacies adopt patient-first models of care, arguably, it would appear everyone is directly benefiting one way or another from the program and its lucrative revenue stream, except for patients. The 340B program has no doubt added benefit for patients and providers alike. The measure of this benefit, however, is shrouded by uncertainty over the lack of transparency and accountability, decline in hospital charity care, as well as the explosive middleman growth in contract pharmacies and pharmacy benefit managers. 29 years after the program's inception, it is now unclear to both regulators and patients, both qualitatively and quantitatively, if the congressional intent is being met.